points, Gates, right? The World Health Organization set out a call for innovative technologies that address global health concerns. A lot of the funding in global health, you can get it if you're going to invent something that goes to market, right? So solar-powered autoclaves for disinfecting surgical equipment. Great idea. I mean, absolutely. You need to have that. There's no question in the world that that matters. But a scalpel is absolutely useless unless there's a trained person behind it who can do it, right? And that they can do it in an effective way. I don't know if you talk to the economist, I mean, like this, the dream of the medical tricorder, right? This is sort of the push, this is the trendy push, that technology, gizmos, phone apps, little things here and there will somehow lead to global health equity. And I'm not content to make that argument because I don't see it happen, right? Unless you truly understand how you get medical knowledge on the ground. And it's why we go back to one of the first medical educators at Hopkins. He said it's why we need to spend more time focusing on the person rather than the disease. And when we really think about the nature of our medical education, the medical sciences, they focus an enormous amount on understanding illness, understanding disease, right? And better rid. There's no question that's improved the quality of life for many around the world, but when it comes to understanding health, I like to ask my students, can you define health? It's a tricky thing. People say, well, it's the absence of illness. Why do we define something for which it is not? What does it really come down to? And what does it mean to create a healthy society? One society that I think has done very, very well in addressing this problem is Cuba. Absolutely resource poor nation. Back in the 1990s, they went through a devastating economic downturn. They lost, after the collapse of the Soviet Union, they lost 35% of their gross domestic product because 87% of their exports to the Soviet Union suddenly disappeared. They were broke. Schools were crumbling down. The average Cuban male lost 30 pounds between 1992 and 1993. Havana experienced 18 to 24-hour rolling blackouts. That's really tough to do surgery when you're in those conditions. Lack of fuel results in mud burning refuse in order to cook. 35,000 people went temporarily blind due to lack of vitamins. Right? This was a very serious health emergency. Just as there is in many other countries around the world, currently Haiti, cholera epidemic, Western Africa, malaria, etc., a massive health emergency. And usually, in times of these health emergencies, governing bodies say, okay, you have to reduce your spending on health care to get your budgets in order, and then we'll worry, get economic development going. But Cuba didn't do this in 1992 to 2001. They said, okay, we have absolutely few resources, but we have people. And the world has a lot of people when you look at it on the global scale, 7 billion of us. Right? And they said, what we need to do is find ways to center and transform health expertise that brings in physicians, nurses, technicians, lab technicians, social workers, you're involved now, and students to things that they call polyclinicos. So these were clinics, but they're also learning centers that roughly served a population of 27,000. But look at this team, almost 86 nurses for 114 physicians and social workers. Why social workers? Because in this time of a very serious health emergency, you need to have a whole interdisciplinary team working on the health of individuals and the community. And they share their knowledges, and they sit down and they collaborate. Nurses and doctors together, having a chat. What's best for the patient? What's best for the community? Right? This method, and during this time, they didn't limit the number of medical spaces or the amount of nursing spaces in their schools, like we sometimes do in Nova Scotia. They expanded them. They expanded them to the point where they could actually bring in foreigners at no cost. So look at the big determinants: infant mortality, under 5, life expectancy, doctor-to-patient ratio. There should be a nurse-to-patient ratio, I get that. But they all improved. They all improved in a 10-year period when Cuba's economy was absolutely in the toilet. This wasn't a minor economic recession. It wasn't a small little dip in the economy. This was an absolute economic catastrophe. And the resources were sparse, but with human resources, collaborative support, institutional support, you'd be surprised what you can do with the basics. It's why the president of the World Bank said, look, Cuba's actually done a really good job in health and education. It's even why Dr. House has said, if there's one thing that Castro's good at, it's how to look good in green. Second, it's how to look good in green and train doctors and health workers. Right? So even the popular sitcoms are getting it now. countries. Why does Cuba's model work so much? They've been able to improve the health of their population, not through advanced gizmos. There is pharmaceutical development, I get that. But by finding methods that people can take care of health issues with basic resources and transfer their knowledge. Right? We know that Cuba's had in the news these days, Hugo Chavez getting cancer treatment in Cuba. Yes, we get that. But you may not have heard about the fact that you've had Cuban doctors provide free eye surgery to 1.1 million of Latin America's poor. They didn't charge them a single dime. Here are some of the patients that we saw. At the top left corner are taxi drivers from St. Lucia, right, who had cataracts. And I was there, I asked them, there's the nurses and social workers with them, and said, why free eye surgery? What's the deal with that? And they said, well, I've got cataracts. I'm a taxi driver. Not much of a taxi driver if I can't see. And so this was a way of not only providing health, very, very easy intervention, but to also help people's livelihoods back on the ground. Little fellow in the bottom there, his mom brought him to Cuba from Mexico after he had a very serious degenerative eye disease. After Hurricane Katrina, which we recall, Cuba had 187 healthcare workers ready to go to Louisiana on call. The US government didn't accept them. There they are. Imagine that, just a whole army of healthcare workers ready to go at any time. Right? There's an enormous capacity. They've worked in Pakistan after the earthquake there for 13 months. And they've sent a lot of their own people abroad, but they realize that you can't send your people abroad forever, even though they do work in the field for long term. So this is why they established the Latin American School of Medicine to train, in this case, over 8,000 physicians from remote and forgotten parts of the earth. And they don't charge any tuition from it. Here's how it breaks down. You get a free 6-year medical education. They received over 17,000 students since 1998. They graduated over 7,500. Students are all foreigners from 36 countries. 101 ethnic groups are represented, and 51% of these medical students are women. Why the last two? Because in the global south, ethnic minorities and women just don't stand the same shot of getting into medical school. They also have dozens of nursing schools across the country for which they routinely offer smaller scholarships to bring in people from overseas. What I see here is that what's really interesting about their approach to medical education is that there's a focus on social and environmental determinants. When you walk in the door, that's the first book that you're given, Health in the Community. They're trained to work in low-tech environments, and part of being there is to demonstrate an emphasis to go back home. That's why they recruit students who come from marginalized regions, right? The highlands of Ecuador, the Amazon, rural Brazil, because we realize that if you're able to provide medical education for those folks, they will likely go back. Rural, humble, underserved environments. They even train Americans from poor areas who can't get into American schools. There you go, the Spanish speakers in the crowd, you see those are the first two textbooks. Health and Medicine is volume 1. That's the starting point. Volume 2, we're going to get on to the social determinants of health that affect individuals and families, right? Before any mention of any of the science that goes into it. So, epidemiology, not an elective. Community health mapping is not an elective either. In-clinic learning, those polyclinics, they have students working very, very closely with nurses, doctors, and social workers, all of them together, right? It's a very hands-on approach, and many of the teachers have worked overseas on Cuban missions abroad. And they wind up in clinics like this, right? Places like Ecuador, women are supposed to survive cesareans on that table, right? But what they do is they do train those willing to serve the poor, and I think that is an enormous benefit. But even then, in the time it's going to take to train 4.3 million health workers, they don't have to be physicians, they don't even have to be nurses, they can be village health workers. For those of you here in India, who have been to India, you'll see that this is quite the scene. This is a Dalit, right, untouchable, not only putting her hands on a priest, taking his blood pressure, and then to do a diabetes check. It's not so much about having a stethoscope in a rural area, right? It's about having skilled people coming in to train and spread knowledge to basically break down social inequities. Right? The sort of violence and gender dynamics that go on in rural Maharashtra are quite sickening. And now when you have the Dalits, here we're doing a diabetes test, right? Very, very easy. In a cup, put the Benedict's region on it, you get a fairly accurate reading where your blood sugar is. Great, and now you control the diet and medicine. Right? Along with it, in the India project, is that you now have these women, semi-literate, as village health workers, you become community leaders. And alongside that, they go on to work to set up their own means of obtaining economic security through organic gardening, selling it, the money stays in the hands of the women, and then microcredit as well. Women who organize. To be a village health worker in this part of India also allows you into microcredit and startup business programs. Now the Cuban connection and the Indian connection are unrelated. There's no connection between the two. Right? Even here we got the kindergarten as part of it, right? These are the healthcare workers who are taking the kids in the morning and teaching them how to read and write. The thing, although the India case where you're training village health workers from the bottom up, the Cuban case where you're bringing in people from rural parts of the world to be trained as physicians, they're not linked, but I'm hoping that one day, when it comes to global health, there's a way to make them meet together. And the question is, where do we come in as practitioners? How can we actually help to advocate so that our medical institutions or nursing institutions can find students, not just always from abroad, but even here in Canada, to work in places like Cape Breton or Nunavut or wherever, right? And how can you, when you're in the field, if you do a global health rotation, what can you do to bring the community to help with the training, right? To bring knowledge, to bring textbooks, to bring resources, to offer courses. I mean, go right back to David Warner's Where There Is No Doctor, right? When you look at a scenario like this, in his book, you know, some people will say, okay, we have to do very reactive interventions. We have to treat diarrhea. We have to, you know, treat the other issues here. But is there a way to approach global health to try to ensure that sort of knowledge translation, economic development, so the health calamities become a little bit less, a bit more easy to deal with? I mean, this is what they do in the Indian model. They encourage village health workers to keep learning and maybe one day become nurses or physicians themselves. And the other element to this I find fascinating is that the village health workers in India do not get paid for service. There's no payment for service. They started doing that in the early days, and the corruption was enormous. And so they said, right, no more payment for service, but we will provide you training for economic autonomy through microcredit and other forms of sustainable farming and agriculture cooperatives. Right? Take the money out of it. That's an incredible part. Now, when you look in India at this project, here's what they've been able to do. The communities that are served by these village health workers, they've taken infant mortality down to record levels in India. Absolutely record levels. Malnutrition. Maharashtra always gets dry spells. The communities that are served by this, in the 1970s, you had 40% malnutrition rates. Today, you have it under 5. Tuberculosis, an issue that still haunts Canada in the north, right? The villages that are served by village health workers in India have taken tuberculosis rates lower to what they are right now in Calabar, just as a comparison, right? And all of this by changing the social dynamics, by empowering women on the ground, by transferring knowledge. So the final thoughts I want to leave you with is that Cuba shows us that it is possible to provide medical education to anyone. You don't have to always come from, you know, a wealthy resource-backed place. You can come from the remote jungle. And in the India case, Project Jan-Ked shows that it is possible to put sound health knowledge into the hands of the poor. That might be a very difficult idea for many to want to do, because we, after all of our training and our medical experience, well, we're the experts. Well, if we're really going to address the lack of 4.3 million healthcare workers and 50,000 people every day not making it, we need to take that second point seriously. Both programs shatter our preconceptions of who can be a caregiver. And I think that's where you will have to come in as students. 2 ways. If you do go abroad, find ways to share your knowledge. Just give it away when you go overseas, right? Be that leader. Be that, like as I say in Cuba, solidaridad, the solidarity, right? And secondly, you are students who do have a very strong political voice for advocacy. And if you are worried that you're not seeing as many First Nations students in your classes, or if you're worried about the enrollments and how we don't bring in foreigners for maybe scholarships, advocate to your deans, talk to them about it, organize. Right? As practitioners and caregivers, should we not work to support such efforts by passing on our knowledge, tools, and skills so that we can have more people taking care of other people? I think that's what it comes down to, because right now, we are living in a world where it seems normal to assume that the quality of care on the right side of the street will be a lot better than it is on the left side of the street. And I think that those 2 methods, by finding healthcare workers in those settings and having village healthcare workers on the left side of the street, we can make a world of difference. So thanks very much for your time. There's 10 minutes for questions if anyone wants to have a chat.
We have a problem of we don't have enough doctors, and a lot of people criticize the fact that the education is low, costs less than outside of Quebec in the world. So, and we don't have any law that obligation of people studying in Quebec that are have to work in Quebec after for 2 years as a doctor, and get back to the society. So in Cuba, the government is paying for the first 6 years. Is there a law that they're obligated to work in Cuba?
No, not at all. I mean, if you're Cuban and you go to Cuban medical school, right, there is an assumption that you will work for the nation. Rural areas or overseas. Now, 3% of Cuban healthcare workers say, no, I'm going to go to Miami and make more cash. They do that, 3% of them. But the foreigners that I talked about, that they're coming in from, I'm told there's been how many now? They're coming from 36 different countries, 17,000 of them, right, are coming in on a scholarship, and if they don't go home, there's absolutely no recourse. There's no penalty, there's nothing. But what we have found by studying it here is that the overwhelming majority do go back to try to serve. The case in Ecuador where I was in, where those physicians went back to rural Ecuador, they were there for a year, and it was the Ecuadorian government who actually fired them after a year. Fired them on economics because they said, we're paying you $300 a month to be a physician in rural Ecuador. Next year, the union obligations say we have to give you a 3% increase. That's far too expensive. Dismissed. And so bring in a new fresh law, right? So if you are in rural Ecuador, there's going to be a consistent stream of people coming in who are maybe quite passionate, but ultimately underexperienced. And I think that there's something to be said about there's a lot of discussion about how, if the government subsidizes your education, you should give back to the community, okay? I've seen this happen, policies work like this in the Philippines, parts of South Africa. They don't always work well. Because if you're a nurse or a medical student, and the last place you want to be is Abitibi-Témiscamingue, and if the government of Quebec says you have to go to Abitibi-Témiscamingue, you will be an awful practitioner because you will loathe your patients. So the next book I'm working on right now discusses this, about what can we do better. And people say, well, you can't restrict someone's choice to move. Okay, that's fine. But are we really giving medical students and nursing students a choice to stay in rural areas? Are we encouraging that? Is the choice to work in a rural, underprivileged area on the same moral plane as it is to migrate to Toronto, or in the case of many physicians in Quebec, Saudi Arabia? So I think that's what we need to do. We need to really focus our choice. Okay.
Hi, Dr. Buish. I'm Danielle McDonald. I'm a fourth-year nursing student here at Dalhousie, and also founder and co-chair of our Dalhousie Nursing Student Global Health Committee. One of the questions that I have for you is what kind of advice you can give to students who want to participate in electives, whether they're in rural regions here in Canada or if they're abroad. What things should we be looking for to ensure that we're not engaging in this medical tourism that is going on?
That's the best question, that right there. I mean, the thing I've found is that with a lot of global health ideas, we hear stories coming from people who have done electives and rotations abroad, and there is that adventurousness into it. You hear stories of Morbinski and Sam Nutt, and they're dodging bullets and this kind of stuff. And that has become so common in global health that we expect that. Do you know what I mean? And it's almost like if we don't have an adventure when we go abroad, we have failed in our rotation because we weren't that adventurous. I think what we need to do is really change the ethics of the pre-departure and post-departure. so that we say, how can we work in solidarity and cooperation? How can, when we're done with our textbooks, send them overseas, send them to these communities? How can we build training models? How can we assist, right? How can we be advocates? The organization that I've worked with a bit in the past, Partners in Health in Haiti, and they also work in Rwanda and elsewhere, they actually discourage those sort of international health practices. They would rather that, if you're going to come to Haiti, you're going to stay there for a while, or if you are a medical student here, set up a reading group, set up a group that studies the political issues that create this inequity in the first place. Because this is, I offer a course on global health, 13 weeks now, we do nothing about this, and I'm always looking for where the nurses and the med students are. And we could do it. We could have a chat and make it go. Cool. Stop.
I've lost my partner in crime, but that's okay. I'll just do it in English, and when he gets back, he can do the French version. We have a couple minutes before we go into our international panel, but I just want to put across a couple more announcements for you all. So a reminder once again, just to follow the conference on Twitter and be live tweeting our events, and it's at CNSA Conference, as well as to like us on Facebook. And just for some clarification on an announcement I made prior, the nomination and campaign period ends at 5 p.m. So that means that all campaign materials must be taken down. So this includes, but is not limited to, posters, flyers, buttons, or feathers. These items must not be seen after 5 p.m. as per our elections policy. So if you're in possession of one of these items, please do not advertise after 5 p.m. Other than that, we will just take a few minutes and we'll get into our international panel. Thank you.
Yeah, it's just like a bunch of nurses and speaking about, I'm sorry. I've never, this is my first national conference. Okay. It's not yours though. Yesterday, because I talked about this. Yeah, why not? There's texting clubs. Oh, are you? Okay.
Je vais juste vous laisser savoir que vous pouvez encore suivre la conférence sur Twitter et sur Facebook à @CNSA Conference. Puis aussi, il y a des petites clarifications encore pour les élections. Les mises en candidature, ça va jusqu'à 5 heures. Après 5 heures, on demande que, premièrement, que tout soit retiré à 5 heures ou avant. Tout matériel promotionnel, les boutons, les affiches, peu importe, puis qu'il n'y a plus de promotion après 5 heures ce soir, des positions. Puis ça finit à 5 heures, c'est ça. Merci beaucoup.
The theme for this year's panel is the nurse's role in decreasing health inequities locally and globally, focusing on public policy and the social determinants of health. Our moderator for this panel is Janet Hodger Roberts,
the Executive Director of the Canadian Society of International Health and Co-Director of the WHO Collaborating Centre for Knowledge Translation and Health Technology Assessment for Health Equity with the Centre for Global Health. Janet is also an assistant professor in the Faculty of Medicine and an affiliate scientist at the Institute for Population Health with the University of Ottawa. She has extensive experience in international public health policy, health systems capacity building, and research. So I'm going to hand the mic over to her so she can introduce the rest of the international panelists.
Good morning. How are you all this morning? Good. So we have an exciting panel, and we're going to involve you at the end, so don't drift off. And we're going to I'm going to walk right down in the audience and grab some of you to get your thoughts on things. So we have three panelists, Connie Clement, Colleen Cameron, and Elsa Jensen, all from Antigonish, right? And we're going to be talking about equity, we're going to be talking about social determinants, and we're going to be talking a little bit about how that links to our work and your work as future nurses, and your work in community involvement, and then get you involved at the very end. So I'm going to first introduce Connie Clement, who's director of the National Collaborating Centre, and there's a bunch of these collaborating centres across Canada on different topics, and this one is the Centre for Determinants of Health. And there's 6 collaborating centres actually across Canada. I'm not going to go into detail about all of everybody's expertise. You've got it, and we're going to weave that into our discussions as well. Okay, and so I'm going to hand it over to Connie.
Hi, I'm thrilled to be here today. You probably didn't know that Antigonish was the center of the international world, right? So I'm going to briefly start by talking a little bit about why health equity is vitally important. And I'm going to do that because even at nursing schools that really care about and understand social determinants of health and equity, you're still going to have a heavy emphasis on clinical practice. That's where most of the